One of the biggest barriers, I think, to having an in-house genetic counselor is that genetic counselors are not recognized as providers by CMS at this point. So that can make billing pretty challenging. That being said, we do still see that genetic counselors across the country bill. If you're working in a state that has licensure for genetic counselors, you're going to have, a higher chance of success with billing and with significant reimbursements.
Does your fertility center have an in-house genetic counselor? Are you thinking about having an in-house genetic counselor? I talk with Amber Gamma. She's an in-house genetic counselor for the RMA network. She has been in-house elsewhere in the fertility field. She's been on the industry side. She has a master's in genetic counseling from Sarah Lawrence College. She is a board member of the Genetic Counseling Professional Group, that subgroup within ASRM. So I asked her what percentage of fertility clinics have their own in-house genetic counselors. That number appears to be on the rise. She talks about the total number of genetic counselors there are in the field. I have her detail what those specific roles are versus which roles are better off for an external genetic counseling telemedicine company. I ask her what kind of revenue an in-house genetic counselor brings in and how much they cost. She gives us tips on how to bill insurance companies for genetic counseling. I asked her to comment a little bit on Dr. Norbert Gleicher's criticism of the overuse of PGT-A. I don't get too deep into that because I'm not qualified to, but I wanted to see if she thinks that having more genetic counseling in-house will utilize less testing, or at least different kinds of testing. And then I needed a clarification from her that you may not need of the overlap between genetics counselors and genetic testing labs. I thought there was a lot more overlap. Maybe you do too. So I asked her to delineate that. We talk about the advantages and disadvantages to genetic counselors' career mobility being in-house versus with a much larger company. And then she concludes with the functions that artificial intelligence will probably take away from the genetic counselor in the next year or two, and what will have to remain within the genetics counselor's purview. Enjoy this episode with Amber Gamma. Ms. Gamma, Amber, welcome to Inside Reproductive Health.
Thank you. Thanks for having me.
I'm trying to think if you're the first genetic counselor that I've had on the show, and I'm going to feel really bad either way, I guess, that I haven't had one over 180 episodes, or that there have been one or two that I'm forgetting, and then I'm going to feel really bad. But welcome. I want to talk to you about genetic counselors in the field, and I want to talk to you about their role in external companies versus being in-house for a fertility center. You are in-house for IVI RMA, and can you give us some context about how many genetic counselors there even are in-house in fertility centers in the U.S.?
Yeah, so it is around, I would say, 20 at the moment. So the National Society of Genetic Counselors does a professional status survey every year. And so in the latest professional status survey, there were about 50 genetic counselors that reported working in this field entirely. So that would encompass your in-house genetic counselors, your PGT labs, your gamete banks. So that is growing. It was about 40 a couple years earlier, so we're growing pretty rapidly. But in terms of the in-house GCs, that's definitely where I think we're starting to see a bit of an inflection point and some more growth.
Of those 20, how many are with EVRMA? How many colleagues do you have at your own company?
So 2 as of today. I was the only one before that.
And so the other 18 that might be out there, do you have any idea what the kind of distribution is between if they're at large group networks or if they're among independently owned fertility centers? Do you have any idea?
You do tend to see a fair number that work in academic centers. So I'm based in New York City. Within the New York City area, a lot of my colleagues are based at, large academic fertility centers. You definitely will see genetic counselors in privately owned groups as well. So specifically on the West Coast within the Seattle area, I have a few colleagues that work, kind of in more private practice. And I will say it does tend to be pretty distributed to the coastal areas at this point. I definitely do have some colleagues in South Dakota, Missouri, but largely you'll tend to see that we do kind of fit along the coast a little bit more.
So we think that there's 50 in the field based on the National Society of Genetic Counselors survey. You mentioned that you thought there's an inflection point going upward for in-house genetic counselors. So that is to say you think that there is a trend of more genetic counselors being brought in-house. Tell us more about that.
I think that we're really reaching a point where reproductive genetics and genetics generally is becoming so important in the field of fertility medicine. And that is because of the technologies that are picking up steam within our field, but then also genetic testing technologies in other areas of medicine. So things like pediatrics, you'll have a lot more genetic testing that goes on for kiddos that have pretty complex medical issues. And then you may find a genetic cause for that child's medical issues. The couple still wants to have more children, so they're coming in for fertility care to be able to reduce that risk. So I think that we're starting to come across some more complex genetic situations where providers aren't necessarily feeling so comfortable dealing with those situations, and feeling confident in their counseling abilities to be able to guide that couple appropriately.
That makes sense why we would expect to see more genetic counselors in the field. You mentioned that it's up 50 from 40 a few years back, but why in-house?
Because for me, thinking about an in-house genetic counselor, it's really all about, what you really deal with, improving the patient experience, right? When we have a couple that comes in and they've had previous genetic testing, for example, the genetic counselor that works at the PGT lab isn't really going to be focused so much on the appropriateness of the testing, how the results will be handled, what we would be thinking in terms of embryos that are eligible for transfer versus not eligible for transfer. The conversation that really happens with the genetic counselor at the PGT lab is more going to be focused on, this is how we set up the PGTM testing. This is the process that we're going to go through. This is what's needed. But there is always a discussion that needs to happen about how is the couple wanting to use these results. If you're finding things like variants of uncertain significance that are not black and white on genetic testing, how are we going to be handling those? Are we going to be testing for them? Are we not going to be testing for them? What are the couple's goals in testing for them? So those are all things that an in-house clinic-based genetic counselor can really explore thoroughly with a couple that may not necessarily be part of the PGT lab conversation.
How do you envision it being structured? Because if there is an inflection point and we start to see a growth there, then I'm guessing we would start to see divisions, departments, or at least teams of some kind. Right now, you're with a really large company. RMA does several thousand cycles in the US,
Yeah.
and you said you have two colleagues right
hmm
now, so there's three of you for this very large company. What will the structure go on to look like?
So there's just two of us at the moment. My second
Okay.
one is starting today. Yeah. So I think that's really going to be dependent on the company. And for example, obviously working for such a large company, it's not like I've just been able to come in and take on all of the genetic counseling that happens. It's really been focused towards things that we feel like are more important to be in-house versus things that could potentially be handled by genetic counselors at telegenetics companies, for example, right? Um, those supporting organizations that can help bridge the gap if there are not in-house genetic counseling services that are available. So over time, what we're really hoping to do as we build the team is be able to bring more in-house to be able to provide a better patient experience, that continuity of care, because also in-house GCs are very familiar with the clinic policies and how we do things. And telegenetics companies, when you're working for multiple different clinics, those genetic counselors don't feel like it's their role to really be able to say, well, this is what's done at your particular clinic. It's more, this is the information that we have about this genetic testing result and the possible avenues that can be considered. So we're definitely hoping to build a team that can help improve the genetic counseling services that we provide by potentially bringing more in-house, and be able to have the resources for our providers to go to and for our nurses to go to when they encounter situations and they need guidance.
Tell me more about those roles specifically and how you see them differentiating from the help that you might be augmenting with at telegenetics companies. You talked about being a resource for the providers, being able to have more background for the processes that you're running at your clinic as opposed to here's just a particular type of test. But as specific as you can be, talk about what those roles will do versus what the external roles might do.
So, for example, I think what a lot of people are facing right now is the issue of mosaicism on PGT-A, right? So, if as an in house genetic counselor, I'm aware of what our philosophy is when it comes to mosaic results, what our transfer policies are, and our workflows. So, things like consent forms that need to be signed, what needs to be in the patient's chart for our embryologist to say, okay, this embryo is going to be transferred. And so it's a much more seamless process for our patients, right? They meet with me, I handle the consent form, everything is in the patient chart, and there's no questions along the way. If you're talking about, an external genetic counselor at a telegenetics company, they're obviously working with many different clients. And as I said, as a separate entity, a lot of those genetic counselors report not feeling comfortable speaking to that particular clinic's policy. So they're going to be saying, well, this is the information and this is the data that we have about transfer of these embryos. Go back and speak to your physician and talk about what their clinic policies are, what pre transfer requirements may exist. And so, as I mentioned, it just kind of creates that more seamless process for the patients, and having, more of a way that they can feel, I think, supported through that process.
That makes sense to me. I'm trying to think of it in terms of economies of scale, and I'm comparing it to something that I know better, which is marketing firms, marketing agencies. And some corporations have in house marketing agencies, and some do it for reasons of cost effectiveness. And it's almost never more cost effective. So even if you
Hmm.
think of very large agencies and very large corporations, you think of a Pepsi, and maybe they're with Saatchi and Saatchi or Universal McCann or Group M or one of these really large Madison Avenue agencies. There will be an entire division that's just on Pepsi, but they're employees of the agency. And so, what about a genetics company that has a dedicated rep for a particular clinic or a particular network where they are trained on that clinic group's philosophy, that clinic group's workflows, has access to put things in their chart, knows their transfer policy? Why wouldn't something like that be able to work?
I think that there are some questions to be asked about, as a healthcare entity, how much access you want to be able to give to external companies about things like patient information, et cetera, right? So usually in situations where we are referring out for those services, it may not be the case that that service has access to the entire patient chart, right? Because is that really appropriate? Do we really want to be giving that access just from like a HIPAA point of view and a regulation point of view? Um, I think that this is more related to patient care as well, right? And so I know that having the relationships with nurses and physicians within the clinic and them knowing that they can come to me, and having spoken with patients and them knowing that I work for the clinic itself, again, I just think provides a better patient experience overall. And we do see this reflected. There was a survey that was done of practice managers that was presented at ASRM last year about people that had hired in-house genetic counselors. And the majority of those participants said we did it to try and improve the patient experience. And they felt like it had done that. So we do tend to see that there is this feeling within the field as well that, having the in-house genetic counselor is beneficial to be able to improve patient care.
Are you working with all of the different offices of RMA right now, all of the providers across the United States?
Correct. Yeah.
How is that workflow managed?
So we have a very clear list of indications for which patients will come to see me. And then we have workflows for other indications. When may a patient be referred to an external service? And so we train our staff really, and we have resources available for the staff. And then it's just habit building over time, right? So over time, the nurses and the physicians have learned they can always reach out to me with a question. I'll always direct them in the correct way.
Well, that's what I
Um,
mean. So even if you have a policy of which patients you see and which patients are referred to an external agency, if you are the only person who this is their sphere within a very large organization, are you not getting pinged with emails constantly about, well, what about this? Or what do you think about these things that aren't even part of your ticketed workflow?
Yeah, yeah, I do get a lot of those emails. And so that is a large part of my day, as well as just being able to provide that support to our providers and to our nurses.
What are they asking you?
They're asking me about carrier screening results. They're asking me about, what do you think about this history or this genetic counseling note that we got? What do you think needs to be done for this patient? Um, and yeah, I mean, depending on the day, it can be a lot of emails, right? But I think that's one of the beauties of having an in-house genetic counselor is that those individuals know that there's someone that they can reach out to, that they trust, and that they know is going to be very responsive to be able to get that answer.
You talked about there are criteria for which patients see you and which patients may be referred to an external company. What are the criteria for patients that are a good fit to be referred to an external company?
It's going to be your more routine things. So things like carrier screening results that don't show an increased reproductive risk. It's the more complex things that come to me where those clinic policies really become important. So things like mosaic embryo transfers, segmental aneuploid transfers, complicated PGT-M cases. So your more routine stuff is going to be referred out, and it's the more complicated stuff that we keep in-house.
What kind of revenue does one in-house genetic counselor bring in?
Yeah. So this is something that the genetic counseling professional group is working really hard on right now. One of the biggest barriers, I think, to having an in-house genetic counselor is that genetic counselors are not recognized as providers by CMS at this point. So that can make billing pretty challenging. That being said, we do still see that genetic counselors across the country bill. If you're working in a state that has licensure for genetic counselors, you're going to have, a higher chance of success with billing and with significant reimbursement. There's a few different strategies for revenue generation. Maybe billing directly under the genetic counselor for appointments. A lot of genetic counselors in other areas see patients in conjunction with a physician, and so the billing is done under the physician's name. There is also the opportunity to think about bundling in a fee. I know some of my colleagues at their institutions, there is a fee built into embryology fees as part of the IVF cycle that generates revenue and income for the physician.
You mentioned some states where there is licensure for genetic counselors. Do you know some of those states off the top of your head?
Yeah, so a lot of the states that I practice in, New Jersey, California, Washington, Florida, Pennsylvania, New Hampshire, Connecticut. It's the majority of the states at this point. I think we're around 30 to 35. And then in a lot of states, like in my resident state, New York, there are active licensure efforts to be able to get bills passed and get licensure in place.
And so those are the states where it's easier to bill directly under the genetic counselor typically?
Yeah, when you look at the data, you do see that the licensure does increase the chance of getting reimbursement from insurance companies.
And those where the genetic counselor is meeting in conjunction with the physician and billing under the physician, does that typically happen in states where there isn't licensure for?
Yeah, it can happen as well in states where there are licensure. It depends on your area of practice. So, for example, if you're a genetic counselor working in pediatrics, all of your appointments are going to be happening in conjunction with the physician. Prenatal appointments, pretty often we see that. I would say it's less common within the field of infertility, but it's always something to consider if you're thinking about getting a genetic counselor and thinking about billing strategies.
This may be a question for a billing person, but I'll ask you in case you know it. Do you know
Mhm.
about the differences between the traditional insurance companies, Aetna, United, Blue Cross, and how they bill genetic counselor time or don't versus the employer benefits companies, Carrot, Progeny, Kindbody?
So we're really lucky. Actually, Progeny recently started to cover genetic counseling services. So we're seeing some changes there. Your big players like Aetna, UHC, Cigna, we do tend to see reimbursement from those insurance companies. I know in New Jersey, Horizon Blue Cross Blue Shield is a bit of a challenge, to get reimbursement. And there are still some insurances that don't credential genetic counselors, but that doesn't necessarily mean that you won't get reimbursement. So Cigna is an example. They don't credential genetic counselors as providers, but if you bill genetic counseling services, we do see that you do get reimbursement in most cases.
I am going to do an episode specifically about reimbursements and negotiating with insurance companies. I have a CEO coming on to talk about that topic. So we don't have to go all the way into it, but what other tips
Yeah.
can you give us for being able to get reimbursed for in-house genetic counseling?
I mean, I think that as much as possible, if you're bringing in a genetic counselor, genetic counselors, it's a small community. We tend to be, connected to each other. And one of the things that the genetic counseling professional group is trying to do is to be able to set up resources that providers who want to bring an in-house genetic counselor have access to on these types of topics. So being able to tap connections in these types of resources is always a good idea. I think the other thing when you're thinking about setting pricing is you always want to consider that sweet spot of being able to try to get significant reimbursement from the insurance company. But if you're going to be balance billing patients in the case that the insurance does not cover the cost of that, you want to be able to have it be an amount that is still reasonable, for the patient to be paying. So, when I've looked into this before, you'll see varying amounts. I've seen like around 100, 150. And these are the types of amounts that people are playing around with to be able to see, okay, what do we get back? What are our patients being responsible for? So I would say it's an ongoing area of experimentation, and there are federal advocacy efforts that are ongoing at the National Society of Genetic Counselors to be able to try and get us recognized as providers by CMS. We're just working on getting ready to reintroduce that bill with the new Congress session. I think once that gets passed, the billing landscape is really going to change.
How much does a genetic counselor cost, and what is the point where it's more cost effective than using someone externally?
Yeah. So again, when you look at the professional status survey data of the genetic counselors that are reporting working in this area, and this includes all settings, you'll see a salary of around 100,000 to 150,000 a year. I think one thing that we do have to keep in mind as well is it's not just necessarily about revenue that is being brought in from the patient appointments. Having a genetic counselor in-house also provides a level of protection for the practice because genetics is complicated. You make one mistake and there's one lawsuit that's brought against, a practice, that's going to be millions and millions of dollars. And so having a genetic counselor that can prevent that money from going out the door when a lawsuit is settled is going to be able to, help offset some of the costs of actually having that genetic counselor in-house. Also, we hear this pretty commonly, the concerns about the salaries of genetic counselors. There are other staff at fertility clinics that do not actively bring in revenue that are seen as crucial and important to patient care, nurses being a perfect example. And over time, we've seen the importance of nursing within this field increase. And I do think that we are going to go the same way with genetic counselors.
I wouldn't say that nurses aren't tied to revenue. They're not tied to a billing. You're not billing the insurance company for the nurse. But if you have an REI that can do X 100 retrievals versus Y 100 retrievals, the number of IVF coordinators that they use is typically variable to that. So they're part of the capacity.
For sure.
Do you see genetic counselors as being able to improve the overall capacity in terms of the number of cycles that can be done with genetic testing?
I mean, I think that having a genetic counselor definitely reduces provider time and having to, try and counsel on genetic tests, try and counsel on results. And through that process, you're improving processes like informed consent, right? So when we think about just patient care from a genetic counseling role point of view, I would definitely say that it reduces provider time. We also know that genetic counselors in fertility clinics are not just limited to seeing patients. They're going to have other roles as well. So this may include things like being part of a third-party program or helping to manage carrier screening workflows or acting as liaisons for labs. And so all of these things can help reduce time that is spent by other staff within the fertility clinic on some of these matters.
So if not about revenue, but about scale, what size of practice group do you think is too small to bring in a genetic counselor? Again, EVRMA is multinational RMA in the United States is still doing several thousand IVF cycles, and you now have one peer at your company. At what point do you think it makes sense to bring someone in?
I think if you're encountering a lot of genetic testing and you are feeling like your staff does not have the confidence to be able to deal with that genetic testing and counsel appropriately on it, I think that's really when the discussion should be starting. So we're working on an abstract for presentation that we're going to submit to ASRM this year, which has just been a survey of in-house genetic counselors across the country. And when you look at the number of cycles per SART, in terms of the clinics that do have genetic counselors, yeah, we're talking about clinics that do tend to be on the larger side, like more than 500 cycles a year, right? But you will see one or two clinics that definitely are on the smaller side that have genetic counselors. So part of it is going to be volume, but part of it is also going to be how important do you feel like having that in-house support is for your patients. As I mentioned, there may be more opportunities at academic fertility centers if there are already genetic counseling resources within the institution itself to kind of form that relationship with those genetic counselors. But I think, really once you grow and you're kind of encountering this more and you feel like that level of confidence is coming down, that's really when you need to start having that discussion.
Does having genetic counselors in-house and doing more of the genetic testing in-house change the type of genetic testing that is done on the aggregate versus using a vendor?
So it will and it won't. The way that it won't, there is this common misconception that has sometimes been encountered that as soon as you bring a genetic counselor in house, that all of a sudden you can do any type of genetic testing. And there's really two different types of genetic testing. You're going to have your screening testing, which is more like your carrier screening ahead of time. And that's definitely things that genetic counselors that are working within fertility clinics feel like it's within their scope of practice to order. One other thing that you may encounter is you may get a patient come in that has a complex medical history with a suspicious diagnosis. They haven't been able to make it in to see a geneticist yet. And sometimes I do get requests about, can we order this testing for this patient? But that's diagnostic testing. That's testing for the patient to be able to establish a diagnosis for them. So that is not genetic testing that, generally fertility GCs feel comfortable ordering because it is not within our scope of practice. That being said, even on the carrier screening side of things, you tend to start picking up on things that may not have been picked up on before you were in house, and testing starts to be ordered for that. So, a good example, you'll get a lot of PGT-M cases these days for BRCA1, BRCA2. Those two genes are associated with dominant conditions, but they're also associated with recessive conditions. So when you're meeting a couple and one of them is positive for one of these two genes, one of the things that we usually think about doing is offering genetic testing for the reproductive partner to be able to see if that partner is also a carrier, maybe is not aware. And so those are the types of situations where you start to see more discussions happening that may not have been happening before you had an in-house genetic counselor.
How about with regard to the prevalence of even doing PGT-A? And the reason I think to ask this is because I recently interviewed Dr. Norbert Gleicher. I think his episode will come out before this one does, but in either event, people should listen to that episode. And I want to make sure that I'm paraphrasing Dr. Gleicher's argument, right? But in a nutshell, he views that PGT-A is far overutilized for lack of scientific consensus, and believes that at least in part it's due to the influence of the lobbying, for lack of a better term, power of genetics testing companies, that in his view they have replaced the pharmaceutical manufacturers as the big spenders at the conferences and have a lot of influence that is based on their sheer marketing power. And we didn't talk at all about genetics counselors being in-house. So I wonder, one, if you share that view, if I'm representing it correctly, and people should listen to that to make sure that I am. But two, if we might see a change in behavior, particularly with regard to PGT-A, if it's not about being referred out to somebody else.
So I'm obviously very familiar with Dr. Gleicher's point of view on PGT-A, and I think it comes from, I think he and I differ in our perspectives, but we share a common criticism of PGT-A. And that's really that if you're going to be bringing a test to market, you need to have a very good understanding about the clinical outcomes for all of the different possible results. So, your chromosomally normal, your PGT-A negative embryos, we know a lot about that because we transfer those routinely. Your mosaic embryos, we've gotten a lot of data on those within the last 7 to 8 years. The one thing that we don't have a good understanding on for most of the labs in terms of what they've actually published is your whole chromosome abnormalities, right? Your plus 21, your minus 1. A lot of clinics don't transfer those. And when you think about the commercial PGT-A laboratories within the US, there's only one PGT-A lab that has done a non selection study and has transferred over 100 of these chromosomally abnormal embryos to be able to understand how many of them make babies, how many of them don't. So that was the Ashley Teague study. They transferred over 100, none of them made babies. So if you don't have a good understanding about the clinical validation of your PGT-A platform, you can't say with confidence to patients when you get a whole chromosome aneuploid result, what is the chance that that would make a baby, right? I've worked with labs that have this information and that don't have it. My counseling with labs when they don't have this information is, yeah, I think there's a very high likelihood that that embryo isn't going to progress to a full-term pregnancy. But because you can have these cases squeak through, that's really what's fueled the Gleicher controversy and sort of that perspective of things. But I think if we could get to a place where all of the PGT laboratories had this information, then I think that critique really dissolves because we have the data to be able to tell us, whole chromosome abnormal embryos with next generation sequencing technology, do they make babies? Do they not make babies?
But then the thought that comes to my mind as a dummy is, why do they not have that information?
Because it's very challenging to do as a study, right? When you think about the Teague study, that was obviously because there was a very close relationship between the PGT lab and the fertility clinic that was really working with them. So, other labs that don't have that type of relationship, how do you really build that relationship to be able to get that study going? And also, as a study, transferring the abnormal embryos, because we know that there is such a high likelihood that they won't result in successful pregnancies, there's a lot of ethical questions that come up, right? It may not be something that all institutions are super gung-ho about doing, even if we know that it is something that is so important to this field.
You talking about this and what you said earlier about one of the advantages for genetic counselors being in-house is that they know the fertility clinic's transfer policy. They know the fertility clinic's philosophies on different things like mosaicism. How much influence will genetic counselors have over those things from the beginning going forward? In other words, how much influence will they have over the transfer policy, over the group's philosophy on mosaicism and other elements?
Hopefully more. I mean, I know at my previous institution where I was before my current position, Um, when I had first started there, the conversation about transferring mosaics came up and the policy was set. And then 2 to 3 years later, I was monitoring the research and the data that was coming out. And I brought it to the physicians and I said, listen, our policy is not reflective of the data anymore. If we want to be an evidence based practice, we really have to reassess this. So I think that genetic counselors in house can be a huge resource for helping to direct clinic policies based on the evidence and based on understanding of genetic testing.
That brings me back to what you talked about with risk. And maybe that's one of the ways that you see in-house genetic counselors being able to reduce legal risk. Tell us more about that. How would an in-house genetic counselor team or even one help a clinic reduce their legal exposure?
hmm So I think embryo disposition is a pretty big conversation now with these intermediate PGT results. So I know some of my colleagues have been really important in discussions with their institution about what do we keep, what do we not keep. Your third party risk assessment, so things like egg donors, sperm donors, especially if you have in house gamete donor programs, they can be really pivotal in being able to assess family histories and appropriateness of gamete donors, and also be able to interpret genetic testing that is being done for those individuals. And then just generally, in your day-to-day practice, being able to make sure that everything is being covered from a genetics point of view. We're not missing anything. Results are being interpreted correctly. Those are all ways that we can assist with that.
If it's so important, as you mentioned, then why are genetics companies closing their fertility divisions?
Genetic testing companies?
Yeah. So why did Semaphore close their fertility division? Why did Invitae close their fertility division? If this is such an important thing and so important that we should be bringing more of it in house, why are large companies parting ways?
Well, I think we have to separate out genetic testing versus genetic counseling. So the genetic testing labs are really the ones where we're seeing a lot of shifts at the moment. And that is having some downstream effects on telegenetics companies that those labs have working relationships with. But the challenge with genetic testing, especially when it comes to carrier screening, which we deal with a lot, has always been that there have been very, very thin margins for that testing. And things changed, around 2018, 2019, in terms of how you can bill for that testing. You could no longer stack codes. Your margins got thinner. We've also changed into an economic climate where capital investment is not as readily accessible. And so I think it's a combination of all of these things, right? And also individual business practice decisions that are really influencing a lot of the layoffs that you're seeing across companies.
Well, maybe this is an elementary explanation that my audience doesn't need, but that I may have benefited from earlier. I thought there was a lot more overlap between genetics testing companies and the genetics counseling services done by telegenetics companies. Can you talk about what overlap there is and isn't?
Yeah. So a lot of labs will have their own independent, like their own group of genetic counselors that work for that lab. But then, especially a lot of carrier screening labs, you'll see that they start to build these relationships, these contractual relationships with telegenetics companies. And that's just simply because they have such a large volume of testing coming in that their in house group cannot cover all of the genetic counseling demand. So they will contract with these telegenetics companies to be able to provide your results reviews for your patients. And so the lab is then directing money towards the telegenetics company through that contractual agreement, but they're separate entities.
Okay, so the closures and the reductions that we're seeing with genetics testing labs, we're not seeing that trend with genetics counselor tele companies?
So, like I said, there are some downstream effects, right? Because if you have a contractual relationship with a genetic testing lab that disappears over a couple months, then you're obviously going to have a gap, right, in terms of what revenue you're expecting as a company. So, a good example is Genome Medical is a telegenetics company that had a relationship with Invitae. When Invitae did a lot of their downsizing and their layoffs last year, there were some layoffs that happened at Genome Medical later on, right? So these are examples of things where we can see more downstream effects that hit telegenetics companies because of genetic testing lab decisions, but it's really all originating from that genetic testing lab.
Not originating from what could be the origin cause, one being insurance billing, that if these lab companies are closing fertility divisions and citing the lack of insurance reimbursement, are we not seeing that same trend in for the counseling companies or for counseling period?
No, I mean, because we talk about billing in terms of the billing codes, right? They're seen as completely separate services. They're billed very differently. Um, And I mean, there are some areas of genetic testing where you see much more successful reimbursement. So oncology, for example, from a lab testing point of view, but we're not seeing the same level of increasing difficulty that we're seeing within the genetic testing world when it comes to billing for genetic counseling.
Is there a disadvantage to genetic counselors' career mobility working for a fertility clinic as opposed to a much larger company, given all of the different tracks that a genetic counselor could go on to do?
I mean, the thing that I've always loved about my role is you can be a trailblazer. So I think this type of role is going to attract a genetic counselor that likes a certain level of independence and likes to be able to be very innovative. I always say I would have been a horrible pediatric genetic counselor because even though we're all trained in the same way, the role is very different, right? Obviously, in fertility, I'm not working directly alongside a physician every single minute of my day. Whereas when you're a pediatric genetic counselor, there's a lot more of that. So, when you think about working for a large company, someone like maybe a telegenetics company, there are certain advantages to that role. Um, you tend to have a lot of patient facing moments. So if you're really into direct patient care, that's a good role for you. Your company can work with a lot of different clients. If you like being able to have the influence and the drive and have a hand in many different pots, that's where I feel like the in-house fertility GC role is really good because you have those opportunities. And your genetic counselors at PGT labs are also really wonderful. Genetic counselors at gamete banks, really wonderful. Like all of my colleagues are very adept and very with it. It's just that our roles differ slightly, right? Your gamete bank GCs, they see their patient as being the gamete donor, not the intended parent. And so their role, even though we all work within the same field, can be different from what I do on a day-to-day basis.
What specific functions will AI take away from genetic counselors in the next 2 years?
I mean, you're starting to see like some pre-test carrier screening counseling modalities coming up that are, like videos and I think are more primed to like AI involvement there. I think at the end of the day, genetic counseling is very much a process of building a relationship within a patient within, half an hour to an hour and being able to really connect with that patient and facilitate a decision about some sort of genetic test or some sort of genetic results. I question about if AI methods are going to be able to bridge that human connection. I mean, obviously, with ChatGPT, things have evolved so quickly. But I think that at the end of the day, genetic counseling really offers an opportunity to be able to connect with a patient that I don't know that AI is really ever going to be able to provide in the same way.
Well, even with Chat GPT, it's like, how do we know that that's real insight? You know,
Yeah,
I think it's going to be a while before we can tell what insight artificial intelligence is able to provide, because we often can't tell what insight real intelligence is able to provide. And at the end of the day, you're helping someone to make a decision that isn't necessarily A plus B equals C. It's
exactly.
multi-factor and people need help digesting it. And so what do you
Correct.
envision the role of the genetic counselor will become as more of the predictive analysis moves to artificial intelligence? What will the role of the genetic counselor become?
I think it's really going to be focusing on those more complex cases where, like you said, the decision is very unique to that patient or to that couple based on what their fertility history is, what their treatment journey has been, where they're at emotionally and financially, and what their goals are in the short and the long term. Those are the areas that I feel like genetic counselors are really going to be able to thrive and build that role. Um, but I agree with you, like there's more predictive things or more routine things that I think there are opportunities for scale and opportunities for technological support to be able to target the resources of in-house genetic counselors to the things that really need it.
There's probably a couple AI companies listening being like, go on. What are a few of those areas where it would help to have more of that support?
I mean, if you think about how often we're doing carrier screening, there's a lot of, let's say that you have a couple where they're both negative on that carrier screening. What's important for them to know? It's important for them to know their results, but it's important for them to know that this test does not decrease all genetic risk, right? And those are the types of things where that conversation is going to look very similar from patient to patient. So that's the type of opportunity that you may think about creating technological support for. Same thing for low risk carrier couples. So one partner is a carrier of something, the other partner isn't. That counseling session looks very similar, but just with some added information about the genetic result that was identified. And then again, risk is reduced, it's not eliminated. But again, those types of conversations look very similar from patient to patient. Those are really going to be, I think, the first areas or the low-hanging fruit for more technological support.
Amber, how would you like to conclude, knowing that of 180 episodes, this may be the first where I've even broached the topic of genetic counseling? And if there have been one or two others, I apologize. But knowing that most of our audience is probably not genetic counselors, I do get notes from them sometimes. And if there are topics that I'm not covering, please do reach out, because this is how conversations like this happen, and we are able to create more content and serve the broader audience. But the majority of our audience being REIs, being execs, being practice owners, how would you like to conclude?
Just that genetic counselors are way more than just people that see patients. They're ways that can support physicians, practice managers, clinical operations directors, and many, many more ways than you think just by hearing about genetic counselors. So, I think having a genetic counselor has been so beneficial for the people that have brought them in that I think it's really worth considering, okay, how can we make this happen in the future? And it's been an honor to potentially be the first genetic counselor that has been on this show.
Amber Gamma, hopefully it's not the last time either. Thank you very much for coming on Inside Reproductive Health.
Thank you.
You've been listening to the Inside Reproductive Health podcast with Griffin Jones. If you're ready to take action to make sure that your practice thrives beyond the revolutionary changes that are happening in our field and in society, visit fertilitybridge.com to begin the first piece of the fertility marketing system, the goal and competitive diagnostic. Thank you for listening to Inside Reproductive Health.